Great, wonderful. So, good morning, everyone. Once again, I'm back at Sundays. This mock test, 110%. I'll give you the guarantee. End of the session, you're gonna get lots of concept clarity of CPR and CPR related things. Usually, I involves the basic things, so lots of things will be cleared. I myself is Dr. Munjal Pandya. I'm basically mat-oncologist and bone marrow transplant fellow, practicing almost close to 20 plus years now in Ahmedabad, India, Gujarat, and have keep deep academic interest. So I'm a coach on the various platforms of PROMETRIC, DHA, HAD, MOH, EMREE, USMLE, and all. So that's it. Without wasting the time, I'll go further. This is Dr. Aarti, who is a consultant pediatrician, also delivering tremendous lectures on various subjects with the specialty in pediatric and neonatologist. She is in my same city. Earlier, used to be with me in my same hospital. She had excellent academic track record and a gold medalist. So she is regularly delivering those who are in coaching. They knows Dr. Maddie again a super this coach. She is in our team for more than 3 4 years now, and she is an internal medicine guy practicing at Oman. Again, a tremendous speaker for cardiology, and her one of the most popular lectures of ECG. Those who have fear or phobia in ECG, there is in our YouTube channel there is a video of ECG interpretation of Dr. Maddie. So you go again, it will help in cardiology as well as CPR. Dr. Ankit again is a consultant gastroenterologist delivering the lectures as well. Dr. Shikha, who is in our team based at Dubai, Esther downtown clinic. She is taking care as a consultant gynecologist. She is also in a team, and we have many other doctors along with her. Is Dipali, and then another team, Dr. Mariam, Dr. Sonal, Dr. Ismail, and few is waiting to join. So it's a quite good team. This is our latest updated books of Prometric 1000 MCQ with answers and explanation, recently updated by me. So those who are fond of books, they can order it online. And we have now various many packages for cost effective, rather I can say. Earlier it used to be a high cost. Now it is at least 60 70% discounted rate, various packages. So you just go through it later on and let me know. Last but not the least, this is our excellent channel. Those who did not subscribe it, I'll strongly recommend you do it. I think if you do at least one video a day before you go to bed, I think your 90% job is done. It is absolutely a concept based, this YouTube channel, right? This is medical MCQ for all, right? And this is bit of old slide, but hundreds of videos is uploaded already, and it is available on Android and iPhone. The mobile application is also available, right? So those who are using it, it's a free download. You can use in Android as well as on Apple device. So whole website, medical MCQ for all, can be accessed from your mobile applications as well. That is also recently updated with the look and feel and speed as well. So it's a very user friendly. And last but not the least, I have mentioned few reasons why people can't crack the exam or they have phobia. So I'll go just little very quick. This I'm just reading it, but whatever is applicable to you, you just go through it and get back to me later on. Unauthentic study material, it's one of the most dangerous things. We are reading from Facebook, Instagram, which probably not much authentic, without answers, explanation. No mentor, so nobody's monitoring you or watching you. That is why you are in your own comfort zone and you feel that I can do it, crack it. I'm not trying to disappoint you, but you need a real sincere hard work. The DHA, what I used to see 10 years before, DHA, hard MOH, or any other prometric, it's bit different down the line, right, in 2025-26, right? So I'm not trying to scare you, but you need a sincere 2 to 3 months of preparation. Those who are part timer, means doing job, ship or house job or doing their own practice, I strongly recommend you take at least 2 months, maximum 3 months. So this is 2 to 3 months project to pass the exam in a first go. How to crack and what to do. If anybody has second, third attempt, feel free to call me later on this my number, mobile, WhatsApp. I'll guide you with my team. And those who are a full timer, those who are absolutely sitting now in Dubai, Qatar, Doha, Abu Dhabi, or wherever, and they're absolutely preparing for exam, 6 weeks, maximum 8 weeks. Don't take much time beyond this, because again, whatever, if you take 6 months, you do the same thing. If you take the 3 months, you do the same thing. And even if you do the 2 months, you do the same thing. Believe me, I'm telling you by experience. So if you are a full timer, don't take maximum 8 weeks, means 2 months. Part timer, take 3 months, because they are doing a job, some uh, practice, going night duties, rotation duties. So it's a bit difficult to spare time. So take one more month. But this is absolutely, I mean, the cutoff time, right? You should get into the system or in the exam in this time frame, depends on your schedule, right? Lack of time management, again, very important, right? In practice and in exam hall as well. I have seen many doctors. I have, sir, 150 question, but I can take only 120. 30 is absolutely gone. 30 is gone is major disadvantage, because out of 120 you have to treat 100 correct, then you are pass. If you are little less, then you are gone, like this. So time management is very important. Make some timetable every day, right? How many hours you supposed to prepare yourself, right? Without timetable, you are like doing it, but it should be haphazard. So make a timetable and see how changes happens in next 1 week, right? It would be more organized, right? Taking the premature date. So don't be like very much, oh, I want to give an exam in 1 week, 2 week. Take your own time. Get a mindset. Only bottom line is that you have to crack exam in first go. Always keep in mind, first time or first go, you have to crack the exam. Whatever the time you take, 2 months, 3 months, whatever, but always keep this mind. Don't think of second time, oh, if I can't crack it in first go, let's see in second go. Never ever. Remove that, completely delete that idea of second attempt, third attempt. Delete it. Think that this is the first and last attempt for you. If you can't crack it, you can't go it. Your body will change, right? Your preparation will change. So don't be in a like own comfort zone. Okay, fine, it's not all about the matter of money, but it wasting the time, money, energy, frustration, a lot of things. When you see your result as a fail, believe me, you give me your feedback. It's a very frustrating being a doctor to see the failure, right? So we are not in hurry, we are not like, but try to do the best of the best, and try to always give a mindset while you're preparing. I want to crack it in first go, right? Consider that only one attempt. Don't consider there are three attempts, only one attempt, right? So that's important, right? And lack of dream. I mean, lack of dream means you need to have a clear cut good dream to crack the exam. So let's start with our main things. These are few important things I thought that let me share with you. So whatever is applicable to you, I'm not, I mean, pointing to someone specific, but something is related to you. I, before jumping, every time I'm jumping directly on the MCQs, but this time I'll little change. I want to give you some concept, and then I'll jump to the this MCQ. So CPR, right? So many people know CPR. What is a CPR? So CPR, first listen this 5 slide, and then in MCQ you can apply all your brain and minds and neurons to get the answer. CPR, the full form of CPR means cardio, means heart, pulmonary means lung, and resuscitation. This is what the meaning of CPR, cardio pulmonary resuscitation. I made excellent acronym for that, right? Just to make your job easy. Many people doesn't know when and where to do the CPR. So see here I see, make it see, no consciousness means C, P means no pulse, R means no respiration. So now onwards, whenever you are in your clinic or hospital, emergency or ICU, if these three criteria fulfill, no conscious, no pulse, no pulse means no heart, and no respiration, in that condition you start CPR. That's it. I think this is the one of the most easiest form. I can make it for you, right? So now onwards, whenever you see a patient, those who have altered or unconscious or no pulse or no respiration, start CPR. So this is the whatever the indication, whatever the condition, you need to see just these three things. If any patient qualify, they start CPR. That's it. This is the, whatever it is, cardiac arrest or whatever the respiratory arrest followed by cardiac arrest, whatever the things, you must keep in mind these things, right? The next step is like one rescuer versus two rescuer. One rescuer is what and two rescuer is what. So let me give you little insight of this, right? So when any patient is unresponsive, he is not responding, right? Or he is unconscious, or all of the sudden he collapse in simple way, all of the sudden he collapse. How you suppose this is from the International American Heart Association. This picture is from AHA American Heart Association, absolutely updated from the one of the latest journal for you guys. So you just keep a watch on it, and there are 100 questions on it. And those who did not did the BLS means basic life support, or ACLS means advanced cardiac life support. This lecture would be, I mean, 90% of their job is done if they listen this lecture well. Their BLS ACLS is 90% done, believe me. Yeah, so whenever anybody is unresponsive adult, right, ensure the scene safety, right? Scene is safe. If something is fire or very bad condition, you don't need to jump into the fire. So ensure scene safety. See everything is safe, then on and you check the responsiveness. If it is unresponsive, there are two things, right? There are two things. One rescuer means there is a one person who can help the this unresponsive adult, one person. Fortunately, if you have two-person, right, who can take care of this unresponsive, little smile, fine adjustment is there, but you need to know. So let's go with the one rescuer, because most of the time when you are there, you are alone, right? So call for the help. Number one, this is MCQ in exam. What you supposed to do? Don't answer CPR. Call for the help. When you are alone, you can't do CPR alone, right? You can't. You will fatigue in next 10 minutes. So first ask for the help. This is first MCQ in exam. There are 100 question in this slide, right? After call for the help, what is the next step, right? Then if right, then and direct someone to get an AD, direct someone to get an AD. This is second step. And third step is to activate emergency medical services. Don't break this chain, right? They will ask you, you ask for the help, what is the next thing? Then second thing, you ask for the help and somebody went to get the AD, what is the next step? If you ask for the help, somebody went for the ED, you call the EMS, what is the next? Like that 100 questions. So one, two, three. After that, you what you do? You did it all these three things, right? What's your next step? Check for the carotid pulse, right? So carotid is the most common where you put the neck, right? So hyoid bone, you just go laterally. You can see carotid. It's on the bilateral. Don't do bilateral. Carotid check, right? If you want to check one by one, but you check one carotid pulse, right? And carotid pulse and breathing simultaneously. I'll just show you the picture to make your thought process clear. So one is pulse. You are checking carotid pulse. Pulse means heart, and you are checking the respiration. That is cardio means heart, pulmonary means lung. So you are keeping watch on both the things, right? So C means cardiac means, and cardiopulmonary, pulmonary means lung. So you are looking at the pulse means heart, and you're looking at the breathing means the lung, right? And you should not waste more than 10 minutes. Within 10 minutes, you need to check. After calling this all people, you need to see the unresponsiveness, and you need to check the pulse. You need to see the whether the patient is respiration is there or not, chest rise is there or not, right? Pulse present, breathing normal, monitor. Pulse is present, right? Sometimes hypoglycemia. I have seen many patients in my OPD, those who have hypoglycemia, especially diabetic, they had taken the insulin, they did not took the, I mean, breakfast or lunch, and they get into the OPD, right, in hurry, and all of the sudden they get collapse. So collapse does not mean CPR. Three things, always keep in mind, three things: no conscious if patient is unconscious, no pulse, and no respiration. Then only CPR. Hypoglycemic patients are not, they are drowsy, but pulse is there. Patient respiration is there. So you don't need to sit on the chest and start one, two, three, four, five. He's live. Come on. Right. So this is common mistake the people are doing, right? So collapse does not mean, you need to see the things, right? So if it is there, pulse present means heart is okay, breathing is normal, lung is okay. So in that case, you don't need to do the perform the CPR, just monitor what happens, right? And if it is no pulse or abnormal or no breathing, in that case you start the CPR, because we qualify: no pulse, no respiration, no conscious, right? Then start CPR. CPR start with the CAB. Earlier it was ABC, few years back in American Heart Association International Guideline ABC. Forget about ABC for cardiac arrest patient or those who have no conscious, no pulse, no respiration. CPR start with the CAB. CAB. CPR start with the CAB. C stands for chest compression. A stands for airway. Open up the airway and maintain the airway. A for airway and B for breathing. This ABC airway breathing circulation FRI for other emergency where there is a no cardiac arrest, there is a no like hypovolemic shock, septic shock, pulmonary embolism, road traffic accident, anaphylactic shock, blah blah, whatever. There are a lot of emergency where ABC applicable for patient with a cardiac arrest where no conscious, no pulse, no respiration, right? The resuscitation start with the CPR and CPR always start with the CAB chest compression, airway breathing. There is a long lecture on each topic, but I'll give you the small and crispy idea about CPR. So first of all, CPR chest compression, right? So 30 compression and 2 breath ratio. I will go bit in detail, right? Compression. This all each and every word here in this slide is a question. Believe me, you'll remember me. So compression. They ask you how much is the depth of the compression. Then it should be 2.5 each or around 5 centimeter. This is a question in exam. How depth? How chest compression, when you are doing the chest compression, how deep it should be. Then 2 inch in adult, we are all talking about adult. We are not now discussing about neonate pediatric, all absolutely adult. What is the rate? How fast you have to give? Then it is 100 to 120 beats per minute, right? So in 1 second you have to press 2 times. That means in 60 seconds you can press up to 120 times. This is ideal guideline as per the all international guideline. Allow the full chest recoil, minimize the interruption, right? And avoid the excessive ventilation. Ventilation is 30 compression, chest compression, 2 rescue breath. You can't have to push 1, 2, 3, 4, 5. You don't need to push the ambu bag right again and again. Avoid the excessive ventilation. That is what it mean to say. And this is what the thing is, right? So this is the basic things, right, about the compression, and there are hundreds of questions with this slide. So those who have, I mean, they can revise this video. I will upload by end of the afternoon once the lecture is over, right? And second, and and other side, right? So let's go little further. The same thing, right? So chest compression 30 by 2 here. What and how you do it? It is all mentioned here, right? And once AD arrives, there is a hundreds of questions, right? Person is doing CPR and AED arrives. What to do? Continue CPR, give AED, blah blah, give epinephrine, give amiodarone, blah blah. Whenever the AED arrives, the number one priority is AED. Number one. Now people are asking me, sir, what is AED? AED stands for A stands for automated, automated. E stands for external, outside the body, external, inside the body, internal. D means defibrillator. Automated external defibrillator, or you can say automated or automatic. Better simple word is automatic. Why automatic? It's like automatic car. You don't need to change the gear. You just drive it. That's it. Everything will be done by the car itself. Same way here, everything is done by the machine only. You don't need to apply your brain 100%. Believe me, you don't need to apply. You just need to apply. And how to apply, I'll show you in the next slide. Right? So this is what the thing is. So once AD arrives, you need to here, right, apply. Stop chest compression, turn on the AD and attach pads to the patient. How to attach and where to attach, I'll show you. And right, once you analyze the rhythm, if it is shockable, give shock. If it is non-shockable, restart the chest compression, right? Once the AD is ready, every 2 minutes you have to do the you have to, I mean, assess for the whether it is shockable or non-shockable rhythm, right? And this is the things. And pause the chest compression, check the cardiac rhythm. If no pulse, even after giving no pulse, right? No pulse, then you machine will decide no shock advice or shock is advised. Shock is advised usually in two conditions. Fix in your mind: ventricular tachycardia, but it is pulseless. Only two indication for shock or defib or defibrillator. Only two indication: pulseless VT or VF. I'm not writing pulseless because VF is always pulseless because heart is not pumping at all. Ventricular fibrillation is never with the pulse. Ventricular fibrillation means pulseless. VT, ventricular tachycardia, they have still the pulse or no pulse. If pulse is there, stable VT. If pulse is not, unstable VT. There are a lot of questions with this. We'll cover it in next couple of slides. Right. So shockable rhythm, ventricular fibrillation or VTAC, or pulseless VTAC is the better word, right? Because VTAC is also seen in with pulse and without pulse. So this is without pulse. So pulseless VT or VFAB, and pause the chest compression, right? And deliver the shock, because shock is advised by the machine. So when you are giving the shock, this is the only time where you supposed to pause the compression or CPR. That's it. Again you restart compression, and this keeps going, right, for at least 30 minutes, right? So this is what the flow sheet or flow chart of the whole complete BLS. So I covered your whole 3 days of one whole day of BLS in two slides. So this is first slide, how the generate, right, and how you need to proceed further. This is the slide chest compression. So your hand should be on this, right? Your hand should be on the, this is the sternum. So in the lower part of the sternum, lower two-third of the sternum, it is very well given here. Here, this is your hand supposed to rest here. This is male, female. You can see the breast shadows of female, but by and large the same, right? Lower third, this is the sternum, right? So lower third of sternum, you put your both the hands, right? The angle is also shown here. You see the shown, it should not be bent, it is tight, and this is the angle. This is ideal condition. You should sit on your knees, right, and give the proper straight hands and back straight, and you push 1 2 3 4 5 6. There are hundreds of videos. You go and check it out in YouTube channel. Because of time I am not playing the videos now, but you can later on check it out. So once you see the videos by my after my lecture, 99% of the things are clear. So chest compression technique, this is international technique. How you supposed to do? 1 2 3 means there are three MCQs, right? Every line is MCQ in this presentation. What is the rate? If they ask 100 to 120 per minute, how much is the compression? 5 centimeter or 2 inch deep, and how frequency? How fast? So 30 compressions followed by two rescue breath, and then repeat. So let me tell you, there are a lot of people confuse 30 compression and two. 30 compression means chest compression, and 2 means two rescue breath. Two rescue breath. So here you are covering the heart, means cardiopulmonary resuscitation. C. Here you are taking care of P. So you are taking care of cardio, pulmonary resuscitation, cardio compression, chest compression, heart compression, that can take care of cardio, and two rescue breath, right? Two rescue breath will take care of lung. So this is what the thing is, right? So 30 by 2 is the compression. This is a standard guideline. I'll show you in the next couple of slides. So this take care of chest compression. What about the respiration, right? What about the respiration? So this is respiration. So you see this slide is cardiac compression, and this stand for C. This is P, right? P means pulmonary or resuscitation. So rescue breathing technique. What's the, right? So how many rescue breath? Two rescue breath. You give the 30 compression to the heart. 1 2 3 4 5 6, like 30. After 30, you give the two breath to the either, right? If you are alone, it is mouth to mouth. It is shown here, mouth to mouth, right? And if you are in hospital setup, you can use the ambu bag as well. Or if you are in ICU, you can use the advanced cardiac or endotracheal intubation or blah blah. You can use it. But the bottom line is that you need to give the pulmonary resuscitation either by hi-fi or by mouth to mouth. That's it. Depends on condition where patient is located or situated, or where this emergency happens, right? So what are the 4 points? This all four MCQ. Open the airway using head tilt and chin lift. Everything is written. So she, there is the arrow, head tilt and chin lift. She is lifting the chin. This is number one. Pinch the patient's nose. Pinch the patient nose. If you can see, the nose is pinched or nose is blocked. Why? Because if you give the air, right, in the mouth and nose is open, it goes from the mouth and remove from the nose, so it will not go to the lung. Your, when you give the breathing or mouth to mouth, it goes to the lung. It should not goes to the nose. That is why it is closed. So pinch the nose and closed. That's it. Important, because this is routine mistake. When this emergency happens in your emergency outside your OPD or in your ICU, then you are clueless what to do. You don't know. You are also panic, right? So don't get panic. These are the all standard step. Inhale the patient's, inhale the place mouth over the patient's mouth, so mouth to mouth, right? Right. And fourth is breath into the patient's mouth over 1 second. It's not like food. You give the full complete breath. So, and when you are giving or pushing the air into the lung, you should watch for the chest rise. See, the eyes of the lady is on the chest, right? So your job is not just to give the mouth to mouth breathing, but you need to look at the chest rise is there or not. So chest rise should be there. And fifth, Kettle. So, and remove the mouth, allow the breathe, right? So this is what the standard thing is, right? So everybody's clear, yes or no? Everybody's clear, yes or no? Anyone, at
Yes.
least tell me yes or no.
Yes, clear,
Yes.
sir.
Wonderful.
Yes, sir.
So yeah, so we'll go little forward and wonderful. So before jumping last questions, this is again high yield questions, right? What is the high quality CPR? What do you mean by high quality CPR? So high quality CPR come right. So this is the high quality. Maintain the chest compression fraction. This could be new word. Chest compression fraction. Can anyone tell me what is chest compression fraction? Above 80%. Anybody has any quick idea about this? Chest compression fraction. So chest compression fraction is something you devote 80% of your time, 80% of your time in compressing the chest and 20% of the time in respiration or less than. So 80% or more time should be devote, right? So that is the high quality CPR. Maintain the chest compression rate. We already seen 100, 120 per minute. Maintain the chest compression depth of 5 centimeter or 2 inch, right? We already seen it, right? Avoid excessive ventilation. This is one of the point in high quality CPR. Right? And last but not the least, allow the complete chest recoil between the compression. So when you're compressing does not feel the heart. You compress means heart is pumping. You relax means heart is filling. So heart pumping, heart blood filling, heart pumping, blood filling. So compression and relaxation, and that is called as a recoil. Recoil means you compress the chest and then get the hand off and try to recoil the chest, right? Because you compressed up to 5 centimeter, right, down to this chest wall, then you allow. So it is called recoil, right? So allow the complete chest recoil between compression. So one compression and two compression, you can't say compression, 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 relaxation, compression, relaxation. That is called chest recoil. That's it, right? So this is what the thing is. So this is all about the, I mean, absolute basic things about the CPR. If I'm not wrong, I think it this without understanding this, you can't answer any questions. Believe me, in any exam. So this is absolutely basic things, and there are 100 questions, different, long scenario. But if you have the logic and clear cut ideas in your mind, I don't think you have any difficulties answering any questions now onwards for this CPR related or some cardiology basic things. Those who missed my earlier cardiology couple of lectures, they are uploaded already on YouTube of our channel Medical MCQ for All. So you go and check it out so you can continue with this a bit more better. This is ADA. Already told you, so I just want you to give the basic knowledge how and what it looks like. So it is machine, right? So green machine, green button, you push it, and then machine is start, right? Automated external defibrillator. It is written here. It is applied on the heart, right? So this is a patient's, right, and this is the machine how it's applied, right? And this is also a little fine version of it. So this is machine opened up, right? When it arrived, here you can see the picture, one pad. So this is, say, this is the, this is the heart. This is heart. So there is a right upper and left lower, two pads. So here you can see it right upper side. So here exactly one pad is attached, left lower one is attached here. So there are two pads, right upper and this is left lower. And heart is like a sandwich in between two, right? So this is the heart, here one and here two. So heart is like a sandwich in between these two, right? Pad, heart is in between. It's like sandwich, right? So right upper, left lower, everything is given on the pad. You don't need to apply. That is why it is called automated. If you open up your eyes, everything and ears, right? Whatever the machine gives you the instruction, you need to follow. Here you don't need to push any machine or you don't need to apply your brain, whether I shock or I don't shock, nothing. You don't need to apply anything. Just on the machine, just on the machine, wait for the instruction what machine is saying. Machine is starting. Please stand away. Apply the pad. Right? Once you apply the pad, please stand clear. Right? It is a non-shockable rhythm. Do not give the shock. It's a shockable rhythm in VT, pulseless VF, pulseless VT or VF. Right? This is all. Everything will be given instruction by the things. You don't need to apply anything. Is that clear to everyone? Yes or no?
Yes, sir.
Yes.
Wonderful, wonderful. And this is the ECG. I sorry to show you the normal ECG, but it's important. P wave is atrial activity, QRS is ventricular activity, T and V. This is normal PQRST, mainly the PQRST. All right. So just to remind you, P is the atrial activity. All right. So atrial depolarization means atrial contraction. After that, once the atria contracts, sinus aortic node, it goes down to the AV node. Right. Means atrioventricular. So ventricle comes contract. So atria contract. Right. And push the blood into ventricle. Then ventricular contract. So this is P is atrial activity for your kind knowledge. So don't. So whatever the abnormality in atria, it will reflect in the P wave. Whatever the abnormality in ventricle, it reflect in the QRS. Simple knowledge. That's it. You don't need to, I mean, it's not rocket science, right? So just you need to remember. And in atria, right, first half, left atrium, right atrium. So right atrial enlargement, you can probably see some kind of this then QRST, right? So you check it out the ECG, exclusive ECG, but just simply remember anything wrong in atria, P wave, atria flutter fibrillation, P wave, you look at the P wave, ventricular tachycardia or ventricular fibrillation problem in the QRS. That's it. This is what the thing is. So this is normal, and let's jump to the main MCQ now. So get ready with your all the things what we have discussed in last 20 minutes would be, I think, worth doing it, right? So you are responding to an ambulance to a wedding where the elderly father of the bride has collapsed while dancing. Bystander says that he was complaining of chest pain earlier, but he did not want to mess up the celebration by doing or going to the hospital. He was dancing when he suddenly lost consciousness, fell on the ground. Bystanders have started the CPR. You arrived and placed the patients on the monitor. It shows sinus bradycardia, but the patient has no pulse rate. CPR continues with high quality compression and ventilation. You are at establish IV line. The only drug appropriate in this scenario would be atropine, lidocaine, epinephrine, amiodarone, norepinephrine. Any questions or any answers you give, let me come to my main flow. This is MCQ. Those who are joining the first time, this is called MCQ. This is question and this is multiple choice. So full form is multiple choice with the question that is known as a multiple choice question. Here, whenever now onwards you are doing any MCQ, ask yourself three things. What is the diagnosis? What is investigation? What is the treatment? So first of all, tell me diagnosis. Those who are giving me the answer, you have the facility to chat box down there. You can post A, B, C, D, E, or you can open up your mic and you can directly speak to me. I need all three things. Any volunteer answer, I need first diagnosis. I will not break this chain. I need investigation. I need a treatment. Though they are asking only one thing, either they ask you exam investigation or treatment or diagnosis, but I will ask you three in each and every question. And if you do this practice, you are a champion, believe me. So, what's the diagnosis? So, there are six, seven questions. Let me check. Yes, Lalita, what's your answer? Lalita. Yes, Lalita.
Sir, pulseless electrical activity.
Okay, so this is wrong answer for your kind knowledge. Now, you tell me what makes in your mind for this pulseless electrical activity.
Sir, there is no pulse and the monitor is showing sinus bradycardia.
Wonderful. So don't take it otherwise. If I confuse you, you stick to your answer. Okay. So pulseless electrical activity. Okay. Why not it is cardiac arrest? Why not it is cardiac arrest? Because in cardiac arrest, there you can't see a sinus bradycardia. Cardiac arrest is flat line. There is a some kind of electrical activity in pulseless electrical activity means some kind of activity is still there, though there is no pulse. Is that clear? Yes or no? Right?
Yes,
We'll
sir.
see that part as well. Fair enough. No worries. So, what do you think? What drug will help to this patient?
Epinephrine, sir.
Epinephrine. Why not atropine? Patient has a bradycardia, so you can't use the atropine in this patient.
Sir, atropine should be given in only sinus bradycardia, but there is no pulse. With pulse and
Wonderful.
sinus bradycardia, we can give
Wonderful,
atropine.
wonderful, wonderful. So when atropine is given, number one, no symptoms. Asymptomatic patient with sinus bradycardia or 50 pulse, what is the treatment? No treatment. This is exam questions. Write down each and every word is question. Symptom, no symptoms, patient is fine. Say for example, 100-meter sprinter, right? Or regular runner, they have vagal overactivity, and most of the all athlete, they have bradycardia. Why? Because of the vagal stimulation, right? Parasympathetic overactivity, you can say. And that is why they have a 40 pulse, 50 pulse, 60 pulse, but they are asymptomatic. In that case, you don't need any treatment. This is exam question. Come to the symptomatic patient. Again, two things: symptomatic patient with pulse, without pulse, bradycardia, we are talking about bradycardia. So with, right, with pulse. So symptomatic bradycardia only treated with atropine, symptomatic bradycardia. But no pulse here, no pulse, no pulse, no palpable pulse. Each and every line is important in MCQ. No pulse, right, patient, then atropine is out of the question, because they don't fulfill the criteria, right? Atropine, where you supposed to, it's symptomatic bradycardia with pulse. That's it. Only three words: symptomatic bradycardia with pulse. That's it. Atropine, only indication, right? Lidocaine, you supposed to know where the lidocaine is used, right? Where the epinephrine, norepinephrine, and amiodarone. So atropine is gone. Lidocaine is usually used in ventricular tachycardia. There is no tachycardia; it's a bradycardia, right? Amiodarone is the drug of choice in ACLS protocol. When you give the CPR shock, and it's all refractory, in that case, you use the amiodarone, right? For the And norepinephrine is like a alpha adrenergic drug which increases the blood pressure. So it is used in hypovolemic shock, septic shock, or wherever you want to increase the blood pressure, especially in ICU. First drip after IV fluid is norepinephrine or NORAD. Both are the same thing. So now I want to understand, Lalita, what is the effect of epinephrine? Effect of epinephrine. Yes, epinephrine. So there are three effects of epinephrine. Epinephrine alpha 1 receptor, it is situated in the peripheral blood vessel, right? So this is situated in the peripheral blood vessel. So it increases the it increases the peripheral vascular resistance. It causes the vasoconstriction, and it increases the blood pressure. Beta 1, it's situated on the heart, right? Selective beta 1
Cardiac.
situated on the heart to increase the force of contraction, increase the increase the cardiac output, and increase the blood pressure. And beta 2, it is situated on the bronchial smooth muscle on the trachea and bronchi, right? So
Bronchial
it
constriction.
relaxes, right? So it
Okay.
help in the bronchoconstriction. Simple and sober explanation, that's it. You don't need to mug up a lot of things, just you need to understand where it acts. So it acts on this receptor, vasoconstriction, increased blood pressure. So it acts on the heart, it acts on the peripheral vessel, it acts on the these things. That's it. So this is what the mechanism of action of epinephrine, and this is applied to all, right? So this is epinephrine, right? There is a head to head comparison between epinephrine. One epinephrine is the same drug, but what is the how it used in CPR, how it used in anaphylactic shock. This is very very important question in exam, and we are always confused. So three questions to the audience: what is the route in CPR? We are talking about
IV.
only epinephrine. Second thing is the dose. Third is the dilution. So here the IV, just to make it fast,
IV.
here the IM. Here
IM.
the dilution, IM, in right. Here IV, here IM. IM, it's lateral wall of thigh, is the base site, lateral wall of thigh. EpiPen is available in Western world and in all Middle East country. EpiPen. So epi means epinephrine and pen. So there is a like a ball pen, what we are writing, right? So it's like a ready to use available injection, right? It is filled with the epinephrine. So it is called as the EpiPen. EpiPen is available in many part of the world, ready-made. You don't need to apply your mind. Adult patient comes with anaphylaxis, get the EpiPen, give the intramuscular lateral wall of thigh. That's it. This is an exam question. The many a times where you supposed to go, deltoid, gluteal, anterolateral, or blah blah. Answer is lateral wall of thigh. Do some research. Why and lateral wall of thigh? Why not on deltoid? Read it. Homework. Dose. Dose here, right? Here you can give the 0.5 milligram, right? And here you can give the 1 milligram every 3 to 5 minutes. Dilution here is 1 s 1000. Here 1 s 10,000. This is absolutely important head to head comparison. The drug is same, but the route is different, the dose is different, dilution is different. That's it. So you need to know. If your question is anaphylaxis, you can't give this on, I mean, CPR. And if they ask you the CPR, you can't use this. You have to answer this. So this is very, very important. I told you already. So just keep in mind, right, about the epinephrine. So this all are the high yield point for epinephrine. So this is what the thing is. Epinephrine is a hormone that increases the heart rate, blood pressure, glucose level, and bronchodilation. Right? It and produced by the adrenal gland. So not going in detail of adrenal gland, adrenal cortex, medulla, what release from where. We'll see sometime in endocrinology, not now. This is what absolutely important for you to understand and know in context of your clinic. We are doctors. It's a life-saving drug. So we need to know head-to-head comparison between epinephrine and norepinephrine. So epinephrine is equal to adrenaline, norepinephrine is equal to noradrenaline. So don't get confused. If somebody is saying adrenaline, it's not a different drug, same as epinephrine. It's a synonym. That's it. Epinephrine, both are released from the these things, right? Adrenal, but little change, right? So this is main production site is adrenal medulla, and this is synthetic nerve ending. See, synthetic nerve ending. Here, primary role is what? Hormone. This primary adrenal medulla. So this is adrenal gland is like triangular shape. Central is cortex and peripheral is medulla, right? So from medulla, it is released from the three hormone: adrenaline, noradrenaline, and vasopressin, or inotropin short you can say. So adrenaline is released, medulla it release. Here the synthetic nerve ending it release. Primary role, it is a hormone with some neurotransmitter effect. Here reverse. Neurotransmitter effect is main, right? But with some hormonal action. Here the most important thing is it acts, as I told you, on alpha and beta receptor. Here it acts only on alpha receptor. So when there is you want to increase the blood pressure, it is a potent drug and it is a favorite drug in the ICU. So when patient comes with a 70 systolic blood pressure or 80 systolic or in shock, first you give IV bolus fluid. This is exam question. After IV bolus, if it is does not get improved, the next immediate and important drug is norepinephrine. Why norepinephrine? Why not epinephrine? Because you don't need other things to increase, right? You need to just improve the blood pressure because and the potent effect is increased blood pressure through vasoconstriction, peripheral, right? So alpha 1, right? That is what alpha 1. I told you alpha 1 on peripheral vessel, beta 1, 2 is on heart and these things, right? And key effect is increased heart rate, right? Dilate the airways, raise the blood glucose. Here primary effect is increased blood pressure. So if you want to increase the blood pressure only in emergency ICU or anywhere, you just give the norepinephrine. Treatment mainly it increases the blood pressure. So where it you supposed to use when there is a patient is hypotension because of any indication you can use this. Here it can use in the anaphylaxis treatment because it has alpha and beta both the effect and cardiac arrest. That's it. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes.
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 Wonderful. Wonderful. So I'm not going much in detail, everything I already told you. Now let's see the couple of quick ECGs in the BLS protocol. You are working in a coronary care unit taking care of elderly female patient who has admitted 48 hours earlier with the diagnosis of acute inferior wall myocardial infarction. She had a stent placed in her LAD, stands for left anterior descending coronary artery, but has not done well. Her husband runs out of the room and tells you my wife does not look so good. You find her to be lethargic. You means doctor, right? You are sitting in ICU. So you find her lethargic, pale, and diaphoretic. Her blood pressure is 60 over to 42. Her pulse is 30, right? You apply the monitor and monitor showing is this rhythm, right? So you identify what's the rhythm. Second degree AV block type 2, sinus bradycardia, second degree AV block type 1 or complete heart block. Take your time, 10 seconds. In exam, you don't have more than 100 seconds for one MCQ. So you have to finish 150 MCQ in just 3.5 hours. So if you calculate it, one question, 100 second, means 1.5 minute maximum, including everything, reading, interpreting, applying brain, and then answering, putting, typing, clicking, going ahead. 100 second all done. That is called time management. So you need to do it now. Yes, anyone? I mean, any comment? I mean, we are more than 40 doctors, close to 40 doctors. Comment is just one or two. That's it. You can answer right, wrong. Forget about right, wrong. It's absolutely academic platform, so nobody will scold you why it is wrong, blah blah. Rather, you will never forget. If you make a wrong, you will never forget. Please post your answer. Unfortunately, I got only one or two answer. Yes,
A.
Lalit. What do you think? Yes, Lalit. You told A. What's difference A, B, or second degree AV block? Can you explain me little bit second degree AV block? How you differentiate first, second, and third? Let me clarify because there are hundreds of questions with this, right? So, what is first degree heart block? What is second degree heart block? What is third degree heart block? What's in your mind? Tell me one line, only one liner answer. Whatever is the concept clarity in your mind, Lalit, you tell me.
Sir, in second degree type 2 heart block, the
We go
PR
with the
interval is
first, sir.
same.
Sorry to sorry to say, we go with the first heart degree, so everybody will learn and understand. So, what do you mean by first degree heart block? What exactly happened in first degree heart block?
Hello.
Yes, yes, I'm listening you. Something happens in first degree heart block.
Sir, PR interval is increased in first degree heart block.
So, increase PR interval. Better
Yes.
word is delay in the PR interval.
Delay. Yes.
But it is regular, right? So it should be
Yes.
more
Yes.
than 0.2 second. We'll see. We have a lot of ECG here. Don't worry. I want to understand second degree heart block, how it differ from first degree heart block. Here, prolongation of PR interval. So this is PQRST, right? But it's gradually increased, but it is regular. We'll see it in the ECG. Next slide. So this is right prolongation of PR interval. First degree, second degrees,
In second degree, the PR interval increases gradually, and then there is a drop.
right? So delay and then drop. Drop is the second degree, and third is
There is a sudden drop in QRS. There is no delay. It's like constant.
I mean, third degree heart block, how you define third degree heart block? Is there
No,
any
I
name
was
for third degree heart block?
second degree type 2 heart block I was talking.
Fine, fair enough. So forget about confusion now. Mobits 1, Mobits 2. I
Yeah.
understood.
In
First,
third
there is
degree,
a delay or prolong. Second
there,
degree, there is a drop. Third degree,
there is complete dissociation. The P and QRS is separate.
okay. So now you look at the things. What happens? Is it P followed by QRS? Because here
No.
is a 1 P, then QRS. Here P, no QRS, then P. Yeah, here again one QRS, here P. Then again here P. This P is not followed by QRS. So 2P, 1 QRS, 2P, 1 QRS, 2P, 1 QRS. What do you mean? What this showing?
Regular interval, but blocking of people's.
Yeah, you can answer, no problem. I'm happy you are at least interacting. So what do you think? What is this? So absolutely forget about sinus bradycardia because in sinus bradycardia there must be P, Q, R, S, T. Just the pulse is right. So here there is no P followed by Q, R, S. So sinus bradycardia is gone. So those who have given the sinus bradycardia is gone. Right now you are confused between this and this. So what do you think? By me, it's a complete heart block because
It's
atria is doing his
complete
own activity,
third
ventricle is
degree
doing
heart
his
block.
own activity. Then there is no association between atria and contra, right? Because in second degree there is no, I mean, this rhythm. Let's check it out. Literature. I have all the evidence-based medicine, so don't worry. Right? Complete heart block. First, understand complete heart block. No association between P and QRS. Right? So there is a P, then R, right? P, Q, R, S, right? Then again there is a P, then there is no association, then P, then no association, then P, then this is P, then this is P. This is kind of complete heart block. Here QRS, then here P, 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 P. There is no association between this, right? First degree heart block. Here the interval is same, interval is same, interval is same, interval is same. This is simpler one. This is the most simpler one. Usually in first degree heart block, you don't need any treatment. That is also important. What is the treatment? You don't need any treatment. Usually in an asymptomatic patient, and many a times you find it incidental detection. When somebody is coming for operation, gallbladder surgery, appendiculotomy, hysterectomy, right? Pre-operative checkup and profiles and all done, fitness, and somebody anesthetist or physician took the ECG and there is a first degree heart block. Oh, whether to postpone the operation or not? No need to postpone the operation. First degree heart block, especially they are asymptomatic patient, it's a right, an asymptomatic patient, no treatment is required. You go ahead with the surgery. This is MCQ in exam. Second, here there are two category: progressive PR prolongation, which is not here. Progressive PR prolongation is not here. Here the PR interval is same. PR interval is same. PR interval is same. Here the progressive PR prolongation, right? Progressive PR prolongation followed by non-P wave, followed by non-P wave and a dropped QRS. So here, right, non-conducted P waves, here non-conducted P waves. Progressive polo, see here progressive. So here and here progressive PR prolongation, and here the drop QRS. So here the P, then QR is dropped. QRS, QR, PQRST, PQRST, right? But drop QRS, right, without prolonging the PR interval. So beauty is that here PR prolongation, and which is progressive, here PR interval is not prolonged. That is the beauty. This is called Mobitz type 1, this is called Mobitz type 2, and this is absolutely third degree or complete heart block. So first degree does not require, second degree type 1 usually don't require treatment. This people likely depends on sign, symptoms, morbidity and severity. You may need kind of pacemaker, and here absolutely you need a treatment. Complete heart block, they collapse, right? So worst is, this is the least complicated, and if you go down, complexity will increase the thing. So you go and read it once again, and there is an excellent picture here, 1 2 3 same, right? Normal ECG first, right? Interval is same, interval is same. Here the drop, right? Here the drop P not followed by QRS. Again P started, right? So here the interval is progressive prolongation every 2 1 2 1. And third, right? Second degree, there are two categories for first degree, then second degree, two category for your knowledge, right? Mobitz 1, Mobitz 2, right? So, and third degree, as you seen, P and QRS means atria and ventricle. It is also called as the idioventricular rhythm. So atria contracting at their own speed and these things, and ventricle is beating by their own. So third degree AV block, commonly known as complete heart block, it's a severe disruption of the heart's electrical system. This condition prevents the electrical impulses from traveling from the atria to the ventricle or lower chamber. And what happens in the third degree heart block? The atria and ventricle beats independently. So P, 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 then QRS. P, QRS, P, 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 QRS, blah, blah. Ventricle rely on a slower backup pacemaker located in the lower conduction system. The result is very slow and often irregular heart rate. So heart rate is irregular, which is not the case usually in first and second degree heart block, though they are slow but not irregular. Third, it's irregular because atria ventricle, there is mismatch between conduction from atria to ventricle. And this is what the thing is: symptoms, dizziness, fainting, fatigue, shortness of breath, chest pain, faint pulse, blah blah. And diagnosis, how you diagnose? The diagnosis is based on the ECG, definitely electrocardiogram, ECG or EKG, right? So you need to look at the ECG. There is no other test or no fancy test replace the ECG. So ECG is number one things. Next questions. Will you, while you were treating your patients, you forget about her husband who was standing in the room watching? He now says he is dizzy and fall on the floor. He is breathing spontaneously at a rate of 18 per minute. You quickly check him and find the skin is cool and calm. Her pulse is 40 per minute. You quickly put on the portable monitor and you see the following rhythm. This is the rhythm: atrial fibrillation, complete heart block, sinus bradycardia, sinus tachycardia. Look at the ECG, it is self-explanatory. You don't need to struggle a lot. Look at the PQRST. Every question, look at the PQRST. That's it. Yes, so most of the people are correct. This is a C or sinus bradycardia, right? Because why sinus bradycardia? Because P followed by QRS and T. P followed by QRS and T. P followed by QRS and T. What is the problem is? It's a long. How you do know 300 divided by 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10 block divided by 10 block. So pulse rate is roughly around 30. That's it. That's it. You don't need to apply. If somebody asks you how much is the rate, right? What please calculate the what is the pulse. Then 300 divided by large pulse. 1 5 square is 1, 2, 3, 4, 5. Simple for whatever is there, you calculate divided. If it is 10 divided by 10, 300. If it is 9 divided by 9, if it is 8 divided by 8, that is pulse rate. That's it. Simple logic, right? So this is a sinus bradycardia, right? There is no excessive, there is a no atrial flutter fibrillation, or no, there is absence of P wave, there is no sawtooth appearance here. Complete heart block is not there. Why not there? Because P is followed by QRS, P is followed by QRS, interval is regular, patient has a pulse, patient has good respiration, right? And it is not a tachycardia, obviously it is a, right, because pulse is 40-50, so 40-50 is ready, not the tachy. That's it. So this is tachycardia. So it's a simple question, but you are confused. So don't get confused in the exam. I also put some easier questions as well. So don't think that every time I'm putting toxic question. So this is normal rhythm again for your knowledge, right? So this is P followed by QRS, then T. P followed by QRS, then T. So this is normal. This is normal, or simply called as normal sinus rhythm. Normal sinus sinoatrial node rhythm. So this is NSR. Usually physician comes and write on the ECG NSR, means normal sinus rhythm. This is tachycardia. Why tachycardia? Block is just 2, 1 and 2. So 300 divided by 2, pulse rate is 150. Definition of 60 to 90 is a normal pulse. If it is less than 60, it is a bradycardia. If it is more than 90, it is a tachycardia. So this is more than 90. It is, that is why it is tachycardia. So this is sinus tachycardia. Why not supraventricular tachycardia? Because P is followed by QRST. P is followed by QRST. We'll see the why. What is the difference between sinus tachycardia and supraventricular tachycardia? We'll see in next couple of slides. Why it is sinus bradycardia? 1 block, 2 block, 3 block, 4 block, 5 block, and 6 block. So 300 divided by 6 block means 50. Anything less than 60 is brady. Anything more than 90 is tachy. That's all. All clear. Concept is fine. Any confusion? Any confusion?
No, sir.
No.
Sir, bradycardia, unless symptomatic, we don't manage it, sir.
Absolutely no treatment is required. It is written in the book, and it is all guideline. Asymptomatic bradycardia does not require treatment. Is that clear? Now let's little more next. You are called to a home of a 48-year woman who was chief complaint is I almost fainted when I got out of the bed. She has been ill for 2 days with nausea, vomiting, diarrhea. She had a temperature until this morning when she finally broke. She feels dizzy. When she sits or stands up, her skin is cool and calming. Her color is pale, her pulse rate is 130, blood pressure is 88/60, her respiratory rate is 18, pulse oximeter is 96 at room air. He has no medical past history, right? ECG was taken and it looks like this: atrial tachycardia, ventricular tachycardia, atrial fibrillation, sinus tachycardia. Quick. Now you have a concept. I shown you everything. I did my best job. Yes, sinus tachycardia. Answer is sinus tachycardia. Yes. Wonderful, wonderful. It is sinus tachycardia because P is followed by QRS. Always basic concept for any arrhythmia, you need to see what is P, whether you can see P followed by QRS and followed by T. If it is there, it is a normal. That is normal. Then decide whether it is a Brady or it is a Takey. That is the next step. But first look at the P, Q, R, S, T. QRS and T, sorry. Got it? So here you can see P, QRS, T, P, QRS, T. Nothing wrong. What is the block? 1 block, 2 block, 2.5 block, even I can say 3 block, no problem, right? So 300 divided by, if you maximum 300 tachycardia, 300 divided by 2.5, right? Then it is more than 100. So it is a tachycardia. So it's a sinus tachycardia. Sinus tachycardia. Is that clear? Yes or no? Yes or no?
Yes, sir.
Wonderful. Sinus tachycardia. I've shown you. Change your gear. Change your gear. Get out of the sinus bradykardia. It's a different. I'm giving you the clue. You are in an emergency department when a 54-year-old male arrives rubbing the center of his chest. He states that it feels like someone is sitting on my chest. He appears pale and his skin is diaphoretic. His radial pulse is strong but fast. His blood pressure is 130 over 80. Pulse ox is 92. He has no past medical history and took no medication except paracetamol for occasional headache. He has no allergies. You take him back to a room, place on the monitor. You took IV line, started something, and you took the ECG. ECG is showing this. Is it atrial flutter? It is atrial fibrillation. It is third degree heart block. It is normal sinus rhythm. What is it? You apply. I already told you. Yes, anyone. Yes, post your answer. It is normal sinus rhythm. You don't need to struggle. Look at the PQRST. That's it. Look at the PQRST. Look at the PQRST. All are regular. P followed by QRST. P followed by QRST. P followed by QRST. Right? So this is fine. This is normal sinus rhythm. Let's come to this. You complete a 12 lead ECG. The results show below. The ECG reveals what? STEMI, unstable angina, right? STEMI inferior wall, STEMI anterior wall, normal ECG. Quick, look at the all 12 leads. It's given, right? Here given V1, V1, V2, V3, right? AVR, AVL, AVF, and V1, V2, V3, V5, 6, right? So this is this three limb lead, limb lead, three augmented lead, and six chest lead. So if you calculate 3 plus 3 plus 6, that is why we called as a 12 lead ECG. 12 lead ECG. How does this word come 12? So this is 12. 1, 2, 3, 4, 5, 6, and 6 chest leads. So total 12. Yes, please. Yes, anyone wants to answer. Yes, Dr. Kasturi, what's your comment? What do you think what it could be and why?
Sir, sir,
Yes,
I
please. Go
think
ahead.
it is option A,
Great.
anterior lateral wall infarction,
Wonderful.
because I
That's
can
correct.
see the ST elevation in V3, V5, V5, and 6,
Wonderful.
V6.
You are absolutely right. So you can see here start from the V2, right? Then
Yes, sir.
V3 also there is elevation. V4 is elevation. V5 is bit elevation and V6 as well. So anterolateral. Those who are coming first time to my lecture, I will give you the things, right? This is the absolutely how you supposed to diagnose where is the things. So this is septal, right? This is anterior, this is lateral, and this is inferior. Cumulatively, I called as a Sali. Sali means wife sister is called Sali in Hindi, SALI. So this is V1, V2. If you have something wrong in V1, V2, look at the septal wall, septal intraventricular septal. Anterior wall, V3, V4. Lateral wall, apex of the heart, V5, V6. And inferior wall, 2, 3, AVF. That's it. That's it. Now look at V2 to V4. So anterolateral. V3, V4, V5, V6, and little bit, right? But absolutely anterolateral. So answer is anterolateral. How it anterolateral? This is the most simplest acronym. SALI, 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 SALI. Remember SALI. If there is a something wrong in the intraventricular septal, you can see reflect on V1, V2, anterior V3, V4, lateral V5, V6, and inferior 2, 3 AVF. That's it. Mug up this. Simple but easy. So whatever they ask you in exam, you have to look at, right? If it is in the 2 lead to ST elevation, 3 ST elevation, and AVF ST elevation, it's inferior wall MI. That's it. Because it is in 2, 3 AVF. Rest of the leads are okay, right? If it is inferior wall, 2, 3 AVF. Anterior wall, V2 to V5, V6. Normal ECG, it's not normal because there is ST elevation. You can't say it normal. That's it. So this is what the small things. It is at length explained in earlier cardiology lecture on YouTube of last week. So you go and check it out. Next question. The patient is placed on the cardiac monitor. This rhythm strip. Look at the rhythm strip. This is the rhythm strip. You immediately recognize this rhythm as a supraventricular tachycardia, ventricular tachycardia, ventricular fibrillation, atrial fibrillation. Very interesting. Yes, go ahead. Post your answer. Post your answer. Look at the PQRST. That's it. Look at the PQRST. Secret of success is to look at coolly and calmly in the exam PQRST. That's it. If you remember this simpler one. Yes, Mahim, what's your comment? Yes, Mahim, Dr. Mahim. Any comment? Yes, yes,
It is
Ishara, what's your
super.
comment? Yes, yes, go ahead. I'm listening you. I want to understand your logic.
So it is narrow complex tachycardia. P wave is there, therefore it is not atrial fibrillation. So if the ventricular tachycardia, there should be broad complex QRS complex. So and ventricular fibrillation, there should be warm like movements. So answer is supraventricular tachycardia due to the tachycardia and the narrow complex QRS
Fair
with
enough.
P.
Fair enough. So can you see the P and T? Where is the P and where is the T? Can you able to identify the P wave and T wave? Just I'm trying to understand. Yes, Safa Aisa, what's your comment?
Sir, this is a tachycardia, sir. It's 300
Yeah, so
divided by 250.
first of all, you fix your mind that this is a tachycardia, right? In general, for your understanding. So this is not a Brady, this is tachy. Now you have
Yes.
to identify it is atrial tachycardia, ventricular tachycardia, or supraventricular because tachy is all three, right? Atrial, there is
Yes.
a tachycardia, ventricle, there is tachycardia, supraventricular. So now how you define, right? Ventricular fibrillation, forget about ventricular fibrillation now. Forget about atrial fibrillation now. No, there is a sawtooth appearance. So you are a bit confused between supraventricular and ventricular. So how you define?
Sir, in this we see the merging of P wave and T wave.
Wonderful, super duper, wonderful. So let me show you the things and then things. This is, I made it for you guys only, right? Did some smart work for you to better understand your this class. So sinus tachycardia, that is ST, sinus tachycardia, supraventricular tachycardia. What's the difference? Sinus tachycardia symptoms are less in general, is more symptomatic. Dizziness, chest pain, fatigue, fast pulse, palpitations, blah blah. Right? Heart rate is usually tachycardia, normal as I told you 60 to 90. But in sinus tachycardia, when sinus is producing the fast heart rate, it won't usually go beyond 50 in general. It won't go usually. You go and check it out. Example, fever, sinus tachycardia, stress, sinus tachycardia, hypoglycemia, sinus tachycardia. There is no cardiac problem, but because of underlying condition, there is a tachycardia. Some kind of infection, inflammation, all have sinus tachycardia and they have tachycardia, but they usually don't have more than 150 pulse, right? And here, usually they have up to 250 or 300. This is one difference. In terms of pulse rate, this is one difference. So any patient comes to you in your OPD tomorrow with 200 pulse, don't think it is sinus tachycardia. Think of something else, likely SVT or VT. Is that clear? Yes or no? Right? Second most important thing is P and T waves are separate. Let me draw the things. P, Q, R, S, and T. Then again PQRST. So here P wave and T waves They are separate. You can identify, oh, this is clear cut P wave. Oh, this is clear cut T wave. Here, the biggest difference is P wave and T waves are overlapping. We'll see it in our things. And treatment, sinus tachycardia, treat the underlying cause. If you have fever, 104 fever and 130 pulse, treat the fever. 104 fever become 98, this becomes 68. That's it. Treat the underlying cause, right? So treat the underlying cause for sinus tachycardia. Here, first line treatment is the carotid massage, unilateral, not the bilateral. Carotid massage. If does not improve, adenosine, verapamil, atenolol, cardioversion. I'll go bit in detail of that as well very shortly. Right. So this is, I think you love it. This slide, you love it. Right. Now let's get back to the ECG. And can anyone tell me where is P and where is T? Now I am confused myself. Where is P and where is T? Let me draw it on paper. P. This is QRS. Then where is T? Then this looks like P. Then where is T? Then when there is P, where is the P? If it is P, then where is the T? So there is the overlapping of P, QRS. I called this T or P. I called it as a T or P. I called this T or P. Is that clear to everyone? Yes or no? Yes or no? At least tell me yes or no.
Yes, sir.
This is
Yes, sir.
supraventricular tachycardia. This is supraventricular. Only biggest two difference in supra. Whenever you answer supraventricular, ask yourself two questions. What is the pulse rate? Is it between 150 to 250? Answer is yes. Okay. And second important, can you able to identify P different way and T different way? If answer is no, it is SVT. How you differ from ventricular tachycardia, right? So ventricular tachycardia, I told you, P is atrial activity, Q, R, S, and then T. So QRS is a ventricular activity. This is ventricular activity. This is atrial activity. Something wrong. Ventricle is fast, too fast. There is no P wave. PQRST, QRS, 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 QRS. This is VT. Simple and sober. This is VT. Where there is no P wave, no T wave, nothing. Here at least P or T are overlap, but they are there. Is that clear? Yes or no? Yes or no?
Yes, sir.
Any confusion? So in ventricular tachycardia, there is no P wave. We have questions on that. We'll check it out in next.
That is the VF, no, sir. That M pattern.
Yes. So this slide you can check it out. This is the normal sinus rhythm. Up is normal sinus rhythm. See, just for your comparison, I put lots of ECG just to make you understand. This is normal sinus rhythm. How come? P, QRS, T, P, QRS, T, P, QRS, T, P, QRS, T, right? See, everything is in well organized manner. P followed by QRS, followed by T. Again P followed by QRS, followed by T. P followed by QRS, T. Is that clear? Here there is nothing. No P, no T, no confusion. Lot of confusion. SVT. Is that clear? Yes or no? You have this rhythm. So now you know this is SVT. Now you know this is SVT. What will you do? Next step. Same scenario, next step. So let me ask you in another way. This is the scenario. What's the treatment?
Vagal maneuver.
I just need to forget to mention this patient is a stable. They have tachycardia but conscious, well oriented. What is the treatment? Yes, quick. It's a simple question. SVT treatment, mug up and fast. Tell me fast. So
Carotid
let me,
massage.
right, wonderful. Carotid massage or vagal maneuver, right?
Adenosine, sir, 6 mg.
So it is step by step. I'll give you the summary. See, there are 4 steps. Mug up this step. It is not directly adenosine. Supraventricular tachycardia. First try with the easiest. Adenosine is not available immediately everywhere. So do the carotid massage. If carotid, this is first step. You cannot skip this step. If carotid massage does not happen or does not effective, next step is adenosine. Next step is adenosine. How much adenosine? First give 6 milligram. If no response, give 12 milligram. If no response, give 12 milligram. Mug up this. If this does not work, I mentioned here in my slide 6, 12, 12 means milligram. If no response, then third is a verapamil. How much is the verapamil? Give 5 milligram. If no response, give 5 milligram. If no response, fourth step is atenolol, that is beta blocker. LOL is beta blocker. All LOL is beta blocker. We use this on WhatsApp. The LOL means for laugh out loud or something like that. I don't know. But LOL is beta blocker in medicine. So any right, atenolol, propranolol, bisoprolol is all LOL is beta blocker. So fourth is beta blocker. And if it does not work, then finally you can use cardioversion. Mug up this 5 sentence. If they gave you an exam, you attempted vagal manure, it does not successful. What's the next? Adenosine. You did vagal manure, carotid massage, adenosine does not work. What's the next? Verapamil. If first three does not work, what's next? This not wait. Is that clear? Yes or no? At least tell me yes or no. Yes or no?
Yes, sir.
Yes or no?
Yes, sir.
This is the block. This is the block. That's it. This is the block. This is the block. Right? So you just need to remember these 3 lines, right? Once again, this carotid massage, adenosine, verapamil, atenolol, and version. That's it. This is pharmacology. When you give the drug which converts the arrhythmia into normal sinus rhythm, it is called as a pharmacological version. Means you are giving some pharmacy or drug. And when you give electrical shock, it is called as a cardioversion. Is that clear? Right, so this is what the thing is. So not going much in detail of this, let's go to another things. While preparing a second dose of adenosine in same patient, SVT patient suddenly lost the consciousness, his radial pulse is extremely fast and weak. You glance at the monitor and realize that the heart rate is increased up to 200. You should prepare immediately to do administer epinephrine, administer third dose of adenosine, begin or you start the CPR, right, or perform cardioversion. Answer. Yes, answer. Yeah, so most of the people say D, yeah, and D is the answer. Perform synchronized cardioversion or unsynchronized if delay will occur. Can anyone tell me? Can anyone tell me? One volunteer, I need it. What is the exact head-to-head comparison between synchronized cardioversion and unsynchronized cardioversion? We learned, we listened, we seen thousands of times. But what's the clarity of synchronized versus what is the exactly head-to-head comparison? So if you don't want to answer, I will give you the quick this on this just to save the time and do more MCQ in next 10 minutes. So this is exactly head-to-head comparison between synchronized and unsynchronized. Unsynchronized means defibrillation, real AD, we seen in first MCQ, automated external defibrillator, right? So here used for organized but abnormal. So here the rhythms are usually organized. Here the rhythms are usually disorganized or deadly rhythm or very bad things, right? Ventricular tachycardia pulseless or ventricular fibrillation where you need the defibrillator, just for your knowledge. Here the atrial fibrillation, atrial flutter, supraventricular tachycardia, ventricular tachycardia with pulse. See, here they have mentioned clear cut with pulse. Here pulseless. So with pulse you do cardioversion or without pulse you do the defib. Timing. At what time you supposed to give cardioversion in synchronize? So you have to synchronize with someone. Synchronize means alignment. You do some alignment with R wave. At that point of time you supposed to give at R wave. Here there is no synchronized. That is why it is unsynchronized. You don't need to wait for anything. Deliver immediately. As and when patient they have cardiac arrest, right? You call the people, you call the AD, you call the EMS you activated, then you start CPR with CAB with high quality compression, right? And once AD comes, immediately you give it. Immediately. You don't need to look at the P wave and Q wave and R wave and S wave. Immediately. As and when apply pad both left upper, right lower, send it like a heart, push the button, let the AD to analyze the rhythm. If say shockable rhythm, push shock. That's it. It is done immediately. Immediately, right? Patient status often conscious, and this is often unconscious and pulseless. So any patient with arrhythmia comes with pulseless, BP-less, considered the unstable, and most of the time you need a unsynchronized. It restores the normal sinus rhythm. It may not. It may not. Right, so that's it. This is what the basic understanding of synchronized versus unsynchronized. So you need to know yourself. This is the next questions or last questions probably for this, and then we'll get a feedback. Your task for this case is assess and manage. Let me get sorry. Half of the lecture will be pending, but we'll do it in the next time. Don't worry. Co-worker comes with 48-year-old man who is complaining of chest pain. His heart rate is 176 or more. He is lightheaded and worried about fainting. You assess the patient's ABCDE and using the primary and secondary survey and request an EKG. You are unsure what rhythm is, but the patient is deteriorating and his heart rate is irregular and fast. You request a cardiology consultant, alert the team. What is next most appropriate step in the management of this patient? You see the rhythm is this. Patient is 48 years. He is complaining of chest pain. He has a tachycardia. You see the airway breathing circulation, right? Using primary, secondary survey, you put it on monitor, right? You see the irregular fast pulse and patient feels it's about fainting, worried because it's very difficult. Heart is running so fast, blood is not pumping well to the brain, and it looks like a fainting. What's the diagnosis? First of all, diagnosis. Without diagnosis, you can't jump on the treatment. Yes, anyone?
Sir, it is monomorphic VT, sir.
Wonderful. It is monomorphic VT. Excellent. So you did the exact diagnosis, sir. There is a monomorphic, means there is a polymorphic as well, right? So mono means same and morphic means morphology. So I'm trying to make job easy. Monomorphic. So if you see the morphology same QRS. Morphology of all waves are looks like reasonably same. It is monomorphic. Polymorphic morphology is bit different. One is long, one is tall, one is short, but it is then QRS, then QRS, then QRS, and then small QRS. So polymorphic. But basically, it's a ventricular tachycardia. Only to whenever you see any ventricular tachycardia, this is step. First, ask for any tachycardia. Don't take it just for ventricular. Any arrhythmia, rather better word is any arrhythmia, including ventricular tachycardia. Ask first question to yourself whether patient is stable or unstable. Stability check, right? Stable, yes. Stable, no. Stable, yes. What is the definition of stability? People are asking me. Three, patient has a chest pain, patient has no conscious, no pulse, no BP, it is unstable, usually, right? So this is unstable patient, right? So, and when patient is a stable, right, it is a difference. So ventricular tachycardia with stable, right? Ventricular tachycardia, stable patient, yes. Then acronym is PALM, PALM. You use the PALM. P stands for procainamide. Procainamide is a drug. A stands for amiodarone. L stands for lidocaine. You go and read it. It is AV blocker drug. And M stands for magnesium sulfate. Hypomagnesemia can cause ventricular tachycardia. That is why magnesium is also. So these are the acronym PALM. So whenever VT I see in my OPD or emergency, my onco patients, I ask first questions, take the ECG number one, look at the ECG, okay, I confirm it, patient is stable or non-stable, patient is stable, I use PALM, procainamide, amiodarone, lidocaine, magnesium sulfate, unstable cardioversion, that's it. Unstable means you don't have much time to do something, you need to do as soon as possible or immediately, right? So it's a unsynchronized cardioversion. So unsynchronized cardioversion is used for the ventricular fibrillation or ventricular tachycardia without a pulse. We already did it. Medical therapy such as PALM, procainamide, amiodarone, lidocaine is used for sustain, right? Especially when they are hemodynamically stable, right? Synchronize, you need to synchronize with the cardiac cycle, especially the R wave. Unsynchronized, you don't need to do anything with R wave, P wave, QRS. You do it immediately, apply AD as soon as possible and gets job done. That's all. So thank you very much all from my side. I try my level best to catch up with the more 10 questions are remaining. I have a 22 questions. I almost solved the 10, 11 questions. So still 10, 11 questions are pending. If you guys are interested, post me directly or in the group or in the feedback that I supposed to finish that 10, 11 in next time, or you are done with the CPR. So before I ending up my session, I need at least couple of volunteers. How did you enjoy quickly? What's the learning or how is your thought process before and after lecture? How did you enjoy? Yes, please.
Sir,
Sir,
it was a super session, sir. Thank you very much.
Sorry.
You explained the complex things in a very simple manner, sir. Absolutely, it was really helpful for you, helpful for us, and thank you very much for your dedication, sir.
Thank you very much. Yes. Anyone else?
Sir,
Yes.
before
Anyone?
attending your lecture, cardiac was my very worst subject. I was in mood to drop it. But
Wonderful.
now, since when I'm attending now, so I'm getting interested and I'm learning. In my weekdays also, I'm trying to learn that I'm going to attend your lecture. So it's very easy now for me. It's very good. Thank you, sir. You're doing hard in easier hard thing in easier manner, sir. It's
That
very
is
good
what
for me.
that is my job.
Thank you, sir.
Thank you very much. Yes, anyone else? Last but not the least. Yes, anyone
Thank
learn
you so
something
much,
new
sir.
and
Thank you so much, sir. Sir, it was really a golden lecture class. Things are so clear now. The
wonderful.
things
Thank you
that
very much,
really
doctor.
confuse in exam, is it SVT, is it VT, is it this, sir? It is really very clear now.
Wonderful.
These are the
Wonderful.
things that are really very confusing in exam.
Wonderful. Thank you very much. I appreciate your
Yes.
patience and cooperation. Yes, thank you. Anyone else?
Cardiology
Anyone
concepts
new?
are crystal clear now, sir. And your
Sorry,
acronym.
Lalit.
Cardiology, sir. Cardiology concepts are crystal clear now. There are some confusion like SVT. I was also confused about the SVT. It is now clear.
Wonderful. You are a brilliant man. Great. Wonderful.
Thank you,
Yes,
sir. Your
anyone.
acronyms are great, sir.
Thank you very much, sir.
Assalamualaikum,
Yes,
sir.
any.
Good
Walaikum assalam.
afternoon.
Yes, Idra.
First of all, sir, thank you, bundle of thanks for your class. Your class is really good, really nice, wonderful explanation. Sir, according to exam, it's a very useful, but in a daily routine life, like I'm doing OPD in a private setup, it give me more boost and more confidence in my daily routine life and my daily cases, in spite of my exam. Thank you very much, sir, for giving me that much confidence and that much knowledge and a good explanation. Thank you very much.
Welcome, doctor. Welcome. Thank you. Anyone last? Those who joined the first time, I need feedback from first timer. I mean, most of the people I know from the chat. I know personally everyone. I talk with almost everyone. Someone who joined the first time or who scared a lot of cardiology.
Thank you so much, sir. You have taken such time and hard work for us, sir. It is like mind blowing. Your effort has to be appreciated well, sir. Thank you so much for this wonderful session.
Thank you very much. I appreciate your kind words. Yes. So don't miss the class. We'll stay tuned and catch you with the next class. We'll update you in the group as well. And thank you very much. Those who miss the class, I'll upload this class by evening. So you can revise, you can do the things, revision, blah, blah, blah. Thank you very much and enjoy your Sunday. Thank you.